Kelli Gross. Good to meet you. Thank you so much for having me. I'm an assistant professor at the University of Utah, here in the mountains in the USA. Thanks again so much. I'm really excited. Feel free to interrupt me if you have any questions or anything. We'll have some time at the end for questions as well. But this is kind of my approach to male chronic pelvic pain and chronic testicular pain. We see a fair amount of it, and it's going back to the research. Just we all see so many patients with this complaint, and it can be pretty tough to figure out what we can do to help them. So today I'm going to talk about chronic orcalgia, a little bit about the background of that, and I'll have a specific discussion on pain after vasectomy and just how we treat that. I'll also go into chronic prostatitis and chronic pelvic pain syndrome, which has a lot of overlap with men with chronic testicular pain. I'll go into a little bit of the background. There's been research on the U-point system at a Cleveland clinic. So I'll go into a little bit about that as well as into pelvic floor dysfunction. Okay, so chronic orcalgia or chronic testicular pain. This is defined as pain to the testis, the scrotum, the epididymis, or any of the structures around the testicle, or spermatic cord that lasts at least 3 months. It's not 3 months, it's not chronic, but a lot of these guys that you'll see earlier will have pain that does continue, of course. So testicular pain ends up being about 2.5 to 5% of all urology clinic visits, so it's very common. We usually don't know what causes it, or at least very frequently don't know what causes it. So 25 to 50% of the time, we're not sure exactly why. It is very commonly associated with other psychological factors. So you'll see men who have 56% of these men will have a somatization disorder, and 50% will have a different chronic pain syndrome outside of the genitourinary tract. Major depression is very common. About 20% of these men will have that, and chemical dependency, so addictions, drug use, etc. Narcotic use as well for treating these pain syndromes is common, and we'll see that in about 27% of these men. So some basic anatomy about the nerves to the testicle. So the testicle itself is innervated by the T10 to T12 nerves, and the epididymis is T12 to L1, and it's innervated by the presacral ganglia. The genital branch of the genitofemoral and ilioinguinal nerve is what innervates the anterior scrotum. And then the scrotal branches of the superficial perineal nerve via the pudendal nerve innervate the posterior scrotum. Some background on pain. So pain, the stimulus causes a release of neuropeptides that includes substance P, CGRP, and so forth, and versus different pathways that involve serotonin and noradrenergic chemicals, and you get the pain response. One thing that also seems to play a factor in some of the pathophysiology from a nerve standpoint is that some micro nerve injury causes Wallerian degeneration. So that's what happens normally if there is nerve injury, is you get, so if you can see that photo in the corner there, the normal nerve versus nerves with Wallerian degeneration, which is, you know, thinking back to medical school pathophysiology, we'll actually see this, these changes, which are normal changes with nerve injury in men who have chronic scrotal pain. Even if they don't report any history of injury, they don't need to have a trauma or anything like that. They still show these changes of having nerve injuries. So you'll see it in 84% of men who have surgeries for chronic scrotal pain and microsurgical cord denervation versus 20% of controls. So it's an interesting pathologic thing. We don't necessarily know why that happens yet. And you see these changes in the nerves that are on the cremasteric muscle fibers, the tissue around the vas deferens, and then other tissues in the posterior cord. So some of the fat and other tissues by the blood vessels. So physical exam is pretty helpful here with, or very helpful for evaluating men with chronic testicular pain. So we're pretty good at determining if there are any abnormalities versus ultrasound. So, and ultrasound is the most common thing that we do for imaging, but certainly not necessary probably the majority of time. So it's about 71.4% sensitive, it's about 91% specific, and has an 88% negative predictive value for pathology and chronic scrotal pain in men who don't have swelling. That being said, you know, if somebody has a small cyst or something like that, is that clinically significant? It's hard to say, or a varicocele, for example. That might be more significant than, say, a cyst, but physical exam is very important. Imaging isn't necessary in this particular situation. We see quite a few men who have pain after a vasectomy. It's overall not super common, but since we get a lot of men who come in from all around the state and the area who have chronic testicular pain, we see quite a few guys who do have pains that specifically started after a vasectomy. So of all men who get a vasectomy, about 1 to 2% of men will have pain that's severe enough to affect the quality of life. Our American Urological Association guidelines say it's something that it's necessary for us to counsel patients on prior to vasectomy. It's again, vasectomies, I think overall are low risk, and as far as a form of contraception, a good form of contraception. It's just patients need to be aware that it is a possibility. So in a trial, this was at 7 months, that 15% of men still had some degree of pain, and 1% of men had pain severe enough to affect quality of life. Now, what happens later, we're not entirely, you know, studies probably still need to elicit some of that better, but it does seem to be more common in men with vasectomies. So at 4 years, 6% of men with vasectomies seek medical care for testicular pain versus 2% who haven't had a vasectomy. So if you can do a vasectomy reversal for these guys, if they have pain after a vasectomy, 69% of men improve with that. A way to tell if they are going to improve is if they have a full epididymis and have pain with ejaculation. That's typical pain that improves with a vasectomy reversal, as well as typical for pain that's caused by a vasectomy. But not all men have this. We do start with conservative management with anybody with chronic testicular pain, and this is going for everyone. And you can treat post-vasectomy pain with the other things that I'm going to talk about as well. So where you start is, so this modifying exertional and postural habits. So men will very frequently hold tension or do things that cause imbalances in the pelvic floor. So if they notice that there's something that's triggering it, or that they're doing, or something like stretching that helps it, it's trying to change those things. And this can be a big factor, but sometimes it takes professional help before they can actually do some of these things. So seeing a physical therapist that specializes in the pelvic floor is typically what we'll do, and they can identify some of those holding patterns that occur and help them remedy them and get to the root of what can be causing their pain. Scrotal support, so tight fitting underwear, a jock strap is helpful because the gravity and the pressure that you get from everything hanging can cause some of that pain. Non-steroidal anti-inflammatory drugs, so ibuprofen we use for pretty much everybody when they come in unless they can't take it for another reason. And that can be very helpful for reducing inflammation as well as treating the pain. And if they have any comorbid psychiatric symptoms, then treating those. So if they have depression or chronic pain syndrome, having them see a psychiatric specialist, for example. They may need antidepressants. And this is true for anxiety as well. It can certainly be comorbid as well, and they benefit from treatment of those other conditions. So if patients fail conservative management, then the research generally shows surgical options. I mean, other than anti-inflammatory medications, they're not great medical options. So pain medications like chronic narcotic medications are typically not very helpful. They're very addictive. They have a lot of side effects. We don't know necessarily yet. There's not really great data yet on some of the medications that we use for chronic pain syndromes, but those certainly are options as well. And some of that's changing. There's certainly research in that area. So things like amitriptyline, for example, gabapentin may be useful as well, but a lot of people will go to surgical therapies just because they're relatively low risk if you do have the specialty to be able to do them. So typically, one thing that we offer that it's a pretty helpful surgery. You see people definitely have a big response after the surgery. It's a microsurgical spermatic cord denervation. So that's where we divide pretty much all the nerves around the spermatic cord to the testicle, and it really works quite well. So we'll get a 70 to 80% of men who will have a complete response, so no pain after a spermatic cord denervation. About 10 to 20% will have a partial response, or will have an improvement, but won't be 100% better. Now, one caveat here is that these men are chosen for this surgery by doing a cord block. So we'll inject a local anesthetic into the cord and see if they have a response. And if they don't have a response, then these numbers are certainly lower. But if they do improve with a local anesthetic and a spermatic cord, they do have 70–80% complete response rate. So it can be pretty remarkable. A lot of these guys have dealt with pain for 10–20 years, and they certainly have a big improvement, which is great. Some men may be candidates for a varicocele repair. They of course do need to have a varicocele for them to respond, but 70 to 90, depend on patient selection, will respond from just having a varicocele repair where you divide the veins to the testicle. Men who've had a vasectomy and have post-vasectomy pain, you can consider a vasectomy reversal for. We don't necessarily do this if they've had a vasectomy and are having pain that isn't related to the timing of their vasectomy. And from our standpoint, we don't necessarily do vasectomy reversal because it's not typically covered by insurance here for our patients, so it's a huge cost for them. And it takes a lot more time to do a vasectomy reversal than a microsurgical spermatic cord denervation, which also seems to work pretty well in men who have pain after a vasectomy. So usually, even in men with vasectomies, we'll be doing this microsurgical spermatic cord denervation first. You can remove the epididymis or the entire testicle. We certainly still do that, but in research, the results are pretty mixed. So you'll see success rates varying from 40% to 70%. I think there's a lot of patient selection. We usually try to do one of these other things. So in most men, we'll try to do a microsurgical spermatic cord denervation. before we remove an epididymis or the entire testicle. I have to say it's not super common that I see people get better after removing the epididymis, but in the right patient, removing the testicle, I think, which would be along with the epididymis, it certainly can help, but we'll generally do that in men who fail a cord denervation. So a little more about a microsurgical cord denervation. So the concept here is to divide all the structures that can carry nerve fibers to the testicle. We do have to keep some things, of course. So we'll preserve the testicular artery. At least if you find a cremasteric artery, then you can save it. I wouldn't say we typically save them. And then the arteries that go with the vas deferens, if you see it and it's easy to get separated, then we will a lot of times save that artery. But again, the one that we try to really save is the testicular artery. Sometimes if we have a hard time identifying the testicular artery, we'll try to save just the vas deferens artery, because since all these blood supplies are connected, but it's typically just the testicular artery. We'll save about 3 to 4 lymphatic vessels. If you divide all of the lymphatic vessels, they tend to get hydrocele. So they have a very particular appearance under the microscope. So we'll try to save a couple here. And then we'll tend to preserve the vas deferens in guys who are concerned about fertility. We sometimes will also divide them if they're not concerned about their fertility in the future. There's not really great evidence of whether it's helpful or not helpful to divide the vas. We do, I kind of wonder, do they get some of the post-vasectomy pain syndrome if we divide the vas deferens, or is that not a factor if we take all the nerves with the vas deferens? I really don't know, but I do wonder if the pain's due to obstruction of the vas deferens, if they can get some pain from that. Still, time will tell, and hopefully there will be more studies that help us delineate that. So the main risks of the surgery, so like I was saying, hydrocele formation can happen after the surgery. In the literature, it's been as high as 20%, even 50%. I would say in practice, it's not that high to have a clinically significant hydrocele. Maybe they have a little fluid, but not, one that we're going back and treating. I'd say it's probably less than 1% of the time. You can have loss of the testicle. So if you're dividing all of the arteries, even if you preserve the testicular artery and take the rest, then they can get some atrophy of the testicle. And if you do accidentally take the blood supply of the testicle, they can have loss of that testicle. In some men, it can increase their pain. It certainly, at least in the short term, will commonly increase pain for the first 6 weeks or so after surgery. But some people can have a long-term increased pain. So this is a picture from a 2015 study that shows kind of the before and after of a microsurgical cord denervation. So you'll see the vas deferens here, the blue vessel loop, and then this, it's hard to see. It looks kind of big, but I'd assume is the testicular artery with the red vessel loop on it. Although I'll say the artery does not usually look that big whenever we divide it out. So since it's not the best resolution of the photo, it might be the artery with some veins with like some lymphatics around it. Because again, I don't really see lymphatics that are pulled out separately. So they may have some lymphatics in here, I would guess. But you can see that the vast majority of the tissue in the spermatic cord has been divided. And it's pretty crazy what's left after. And the way we'll do it is we'll just kind of divide all this tissue. So with electrocautery, we can divide the cremasters, and you'll actually see it when we do it on, either side, tied off all the veins and things. So here is a study from 2015 that was a multi-center study looking at microsurgical spermatic cord denervation for men with chronic scrotal pain. This is the one that was in the last picture. So they had 50 patients with chronic scrotal pain who were prospectively selected. All of these patients were given a spermatic cord block with a local anesthetic, and all these patients did respond in some fashion. They don't have to necessarily have complete response to their pain, but they do have improvement temporarily. In these patients, they didn't have any intraoperative complications. They had 2 operations for hematocele and hydrocele out of 50. And then at 6 months, 80% of men were pain-free, 12% of men had improved pain, and 8% had no change in their pain. Other therapies, and a lot of these are kind of, since spermatic cord denervation is proven in these patients to really be pretty effective, some of these are things that we'll do if they fail spermatic cord denervation. So ultrasound guided targeted microcryoablation of the spermatic cord. I've never done, I've heard of people doing it. Our radiologists would do it, but I haven't really referred anyone to that. I don't know how common having that expertise is either. So there was one study showed there's 56% reduction of pain at 1 year in patients who failed a denervation. Other therapies, Botox has been looked at. It looks like about a 20% response. And then injection of amniotic fluid is something that we'll do from time to time. We have, this processed amniotic fluid called AmnioFix is usually what we'll use, but there's a lot of different manufacturers and things. So in men who failed a denervation, they found a 50% reduction at 6 months in chronic pain in these patients. Oops. And I'll go on to the chronic prostatitis, chronic pelvic pain syndrome, unless anyone wants to go over any particular questions or anything about the chronic testicular pain. There is a fair amount of overlap between men who have chronic prostatitis and who come in with chronic testicular pain. One physical exam finding that can be very helpful for men with chronic testicular pain is if you do put a finger into the ring like you would if so you're doing a hernia exam. If they have quite a bit of pain with that, those men tend to really respond to doing a spermatic cord denervation. Men with prostatitis, you'll typically see of course, physical exam findings. If you do a prostate exam, it's boggy sometimes. They'll have pain. It reproduces some of their pain. And men who have testicular pain as well as pelvic pain, I'm thinking more chronic prostatitis, chronic pelvic pain syndrome. If they have tenderness of the pelvic floor muscles when you're doing a prostate exam, I'll usually check them at the same time, and that tends to be more of a chronic prostatitis, chronic pelvic pain syndrome. So I kind of treat them a little bit more this way. There's a lot of overlap, and some guys you kind of have to go through both pathways, but for men who have more chronic testicular pain, are really bothered, we're doing a lot of spermatic cord denervations. So prostatitis specifically, only about 5 to 10% of prostatitis is bacterial. It's really not a major factor. So we're trying to move away from treating these guys with antibiotics initially, since it's really not incredibly common. Now, if you do a urine test, if they have bacteria, if they have certain findings of a bacterial prostatitis, we will do antibiotics, but the majority of guys who come in, we really don't find that. So we don't treat them with antibiotics if we can avoid it initially. The mean age of onset in men with prostatitis is about 42 years old. They'll typically complain of pelvic pain as well as lower urinary tract symptoms, which can be variable. Sometimes it'll be mild lower urinary tract symptoms, like they have a little bit of burning with urination or like kind of a tingling sensation with urination. I'd say another symptom that is more common is these men will have some pain with ejaculation. That's a dull pain. You see that with chronic testicular pain as well, but you certainly see it a lot in men with chronic prostatitis. And yeah, pain at the tip of the penis, I would say, is also very common, as well as the pelvic pain in men with chronic prostatitis. There's 4 types of prostatitis according to NIH. So the first type is acute bacterial prostatitis. The second type is chronic bacterial prostatitis. The third type is chronic prostatitis, chronic pelvic pain syndrome, which is what we're going to be talking about. And fourth is asymptomatic prostatitis. So chronic prostatitis and chronic pelvic pain syndrome, the definition is that you have to have this for at least 3 of the 6 preceding months with no other identifiable cause. And we've seen in studies that the level of pain that they have is also associated with having some degree of a sexual dysfunction. 63% of men with chronic prostatitis, chronic pelvic pain syndrome will complain of testicular pain. So there is a fair amount of overlap. And sometimes we're treating them for this chronic prostatitis and the testicular pain improves, but sometimes we're also kind of going down the pathway of treating them specifically for the testicular pain that I just discussed. So this is the NIH chronic prostatitis symptom index. So it talks about pain or discomfort. So it's asking if they have any discomfort in the perineum, in the testicles, tip of the penis, whether or not it's related or that's not related to urination, as well as below the waist and kind of the lower abdomen. It asks about pain or burning during urination, pain during or after ejaculation, and having to urinate after finish urinating. And then there's quality of life questions. So how much does it keep you from doing things? How much do you think about your symptoms? So it checks those 3 different domains: pain, urination, as well as quality of life. So what causes chronic prostatitis? There's a lot of different potential factors that have been studied. So is there a role of infection? We see bacterial DNA more commonly in this men. They're more likely to have a history of a sexually transmitted disease in the past. However, if you look at and see if there's any pathogenic bacteria in the prostatic fluid, it's not increased in men with chronic prostatitis. It's actually pretty similar to controls. So, you know, it doesn't seem to play a huge factor in most of these men, but could it be a past infection? Hard to say. Now, inflammation and autoimmune causes could be a potential source. So these men tend to have higher concentrations of inflammatory cytokines like interleukin-1, tumor necrosis factor, interferon gamma. You also see T-cell proliferation responses to prostate antigens. There's probably in a lot of men some neuropsychological factors. So pain sensitization pathways have been studied in different chronic pain conditions. And having pain does tend to reinforce those pathways. So people with chronic pain syndromes will tend to be more sensitive to pain. In a lot of men, there's certainly a stress factor where if they're more stressed, their pain's worse. Could that have a muscular source where they have more tension in the pelvic floor, potentially? A lot of these men will catastrophize, and you'll see that very frequently in guys who come in where, you know, just because one thing's bad, everything is a catastrophe, everything is, you know, terrible, and things are kind of blown out of proportion. I'd say that's very common in these men. They're very, very concerned about having their pain. They think they have cancer, etc. Not all of them, but it certainly is common. Some of these men have poor social functioning, and other psychiatric comorbidities are pretty common. So anxiety and depression are very common in these men. So there's also some potential causes. So having either dysynergic voiding related to neurologic issues, but also dysfunctional voiding, where instead of relaxing to void, they clamp down, and they can have some bladder neck hypertrophy. There's some studies that show that there may be some urinary reflux in the prostate itself, and the pressures in the prostate are higher. There have been things that show that they may have some abnormalities in the adrenal axis. We certainly do see pelvic floor muscle dysfunction in these guys, and potentially some entrapment of the pelvic nerves that are causing pain. Some of these men have predisposition to inflammation or oxidative stress in some studies. There can be a lot of potential things that are contributing. So for chronic prostatitis and chronic pelvic pain syndrome, there's a lot of medical options for this versus chronic testicular pain. So alpha blockers like tamsulosin, et cetera. These are one of the first lines that we'll typically use, especially in guys who do have any sort of voiding symptoms. We'll try these. They don't have too many side effects. They can be very effective. So very commonly used. 5-alpha reductase inhibitors like finasteride, dutasteride can be helpful, especially in guys with voiding symptoms, but they take a while to work. So not everybody's interested in that. And I'd say people kind of complain about the side effects of these more, which are often pretty vague. So sometimes sexual side effects. I'd say people probably stop their 5-alpha reductase inhibitors more often for me. Antibiotics, especially if there's a sign of any sort of bacterial infection. Pain medications, so we try to use ibuprofen. Things like pregabalin or gabapentin are helpful, especially for neuropathic pain. There's phytotherapy, so these are like over-the-counter supplements like pollen extract and bioflavonoids, like quercetin. There's some evidence that that can be helpful. Botox, we talked about in chronic testicular pain, doesn't necessarily have great evidence, but they've been talking about like injecting the pelvic floor muscles. Some people do that. Allopurinol has been looked at, and traditional medicines. So this is one study looking at quercetin. So it's men with chronic prostatitis, chronic pelvic pain syndrome. This was a prospective double-blind placebo-controlled trial. So they took 30 men who were randomized to 500 milligrams of quercetin twice a day for 1 month versus placebo, and they did show a fair amount of improvement. So on their chronic prostatitis symptom index, lower is better. So in placebo, they started at 20 and went to 18.8. In the quercetin group, they started at 21 and went to 13. So this was statistically significant. And of looking at just the guys who improved at least 25%, only 20% of guys in the placebo group improved 25%, and 67% in the quercetin group improved. And 2 men left the placebo group due to worsening of symptoms. So this is, quercetin is just an over-the-counter supplement. They study one formulation that's called ProstaQ that patients can get online. It's not incredibly cheap, so it's certainly an option, but a lot of guys will just use the over-the-counter supplement of quercetin. I don't know how available it is for you guys, but you know, a lot of our guys will get it on the internet. It's not necessarily even super available in stores for us, but they can get it on the internet. This is looking at a pollen extract in men with chronic prostatitis, chronic pelvic pain syndrome. This is a multi-center randomized prospective double-blind placebo controlled trial. It looks at 139 men and treated them with pollen extract. Those men who increased or decreased on their symptom index by at least 25% was seen in 70% of men who were in the pollen extract group versus 50% of placebo. So these, you know, are preliminary studies that seem to be effective. So non-pharmacologic therapies, these aren't super well studied, include acupuncture and electroacupuncture, local thermotherapy, extracorporeal shockwave therapy. They're actually studying this since shockwave therapy has been so big in men's health, and you know, they've been studied in peyronie's, not very effective in peyronie's, but for erectile dysfunction, you know, it could potentially, there are some early studies that show that shockwave is potentially helpful when administered to the pelvic floor for chronic prostatitis. So we may be hearing more about this in the future. So this is myofascial trigger point release. So having a pelvic floor physical therapist or other trained professional look for knots and trigger points to see if there's any musculoskeletal things that can be worked out. Biofeedback is helpful, and providing psychological support for men who are suffering from any psychological comorbidities or are very stressed, et cetera, about dealing with these things. Prosthetic surgeries, typically not a great option. Don't do it that much. It doesn't seem to be very effective. But if you have a guy who's, you know, a candidate for another outlet procedure because of their voiding symptoms, some guys will improve just from that, but we don't typically do it specifically for chronic prostatitis. So this is looking at who gets chronic prostatitis and what happens. So they recruited 488 men. They found a negative impact on mental and physical domains of quality of life. These men were less educated, tend to have lower income, tend to be more unemployed if they had severe symptoms. And most of these men, 95%, were treated with antibiotics. And again, we were saying that most of these cases aren't bacterial, so they don't necessarily have long-term improvement different than they would otherwise. And this is looking at men who have muscle tenderness in chronic prostatitis, chronic pelvic pain syndrome. So they had 384 men with chronic prostatitis, chronic pelvic pain syndrome, and 121 asymptomatic men. 51% of the chronic prostatitis patients and 7% of controls had tenderness on exam. So they looked at different sites of the prostate, genitals, abdomen, pelvic floor. The tenderness didn't correlate with inflammation or infection in the prostate fluid, but those with prostate tenderness had high chronic prostatitis symptom index scores at baseline as well as at 1 year. So those who had physical exam findings of pain were more likely to suffer from symptoms, not surprisingly. So this is discussing the U-Points system. So this was developed by Daniel Shoskes in Cleveland Clinic. So he kind of developed a way to separate different men with chronic prostatitis, chronic pelvic pain syndrome, looking at what kind of symptoms they have and looking at their symptom severity. So this is a website. If you go to upointmd.com, it's accessible for free for any medical professional or patient, to be honest, but it's targeted for medical professionals. And it looks at urinary, psychosocial, organ-specific, infection, and then neurologic, systemic, and tenderness domains, and gives different ways to measure that, and then different treatments for different patients. So if they have, for example, urinary symptoms, then they recommend, depending on symptoms, either like alpha blockers for urinary symptoms, or if they have more urgency frequency kind of symptoms and are emptying their bladder, then we'll do antimuscarinics, or they recommend antimuscarinics. Dietary changes for pretty much everybody. And kind of depending on how they score in each of those domains, you know, they may have multiple treatment options that are recommended. So for the urinary domain, for them to be treated, the criteria is they just have to have a chronic prostatitis symptom index urinary score greater than 4, or at least this is when they recommend treating that domain. Or if the patient complains of bothersome emergency frequency nocturia, or if they have an elevated post-void residual, you treat them like, you know, a guy with BPH. So dietary modifications, alpha blockers, antimuscarinics. If they are emptying their bladder, you can consider a PD or alpha reductase inhibitors, but again, those will take a while. Men who have psychosocial things, so even diagnosed clinical depression, evidence of catastrophizing, so helplessness and hopelessness. Then they recommend psychologic support, so it's cognitive behavioral therapy, treating anxiety and depression, and counseling. So the organ-specific domain, those are prostate-specific symptoms. So they have prostate tenderness on exam, they have leukocytosis in the prostatic fluid, they have hematospermia. If you do an ultrasound, if they have extensive prostatic calcification, and they recommend in these guys dietary modification, quercetin, and then if they have symptoms of prostatitis, then doing intravesical therapies like you would for interstitial cystitis. And the infection domain, so this is, not men with acute prostatitis, but if they do have some infection that's localized to prostatic fluid, then they would recommend treating with antibiotics. So if or cultures are positive. And so it's like a 4+ week course of antibiotics when we're treating prostatitis. In neurologic domain, they say if you have pain beyond the abdomen and pelvis, other comorbidities like irritable bowel syndrome, fibromyalgia, chronic fatigue syndrome, they recommend neuroleptic drugs, amitriptyline, nortriptyline, pregabalin, for example. And then the tenderness domain is if they have muscle spasm or trigger points in the abdomen and pelvic floor, and they recommend pelvic floor physical therapy, myofascial release, stretching, paradoxical relaxation, trigger points injections, which we'll go a little bit more into very briefly. I'm trying to finish up so that we have time for questions. So this is if you go to the website, this is what you see. So you can actually like drop down and do each of the domains. And if you've done it, you put it in. And if you haven't, you leave it blank, and then you submit it at the end, and they'll talk to you about each of the scores. So this is a study that he had just looking at how patients respond to using this. This is a retrospective review of 100 patients that were offered multimodal therapy based on this phenotype. They had about a 50-week follow-up at median. And most men had about 3 positive domains. So organ specific was the most common. So where they have prostatitis or prostate specific syndromes. Tenderness was very common. Urinary symptoms was also very common. Neuromuscular sort of symptoms were a little bit less common, 39%, psychosocial symptoms at 37%, and then infection was least common, about 16% of men. And looking again at the results, so 84% had at least a 6-point fall in the chronic prostatitis symptom index, which is 25%. Quercetin use was associated with greater increase in the symptom index. 51% had over 50% improvement in their symptom index, and 84 had at least 25% improvement. And this is versus about 17% in men who, in this chronic prostatitis collaborative research network study we talked about a little while back, at 1 year. So it's certainly, at least in this study, a greater improvement than otherwise. And they improved in all domains, pain, urinary, as well as quality of life. So this is a little bit about the male pelvic floor exam, which is relevant when we're talking about chronic or pelvic floor physical therapy. This is a book that I'll often talk to patients about. It's kind of discussing a lot of pelvic floor physical therapy techniques that they can do on their own. So if you have guys who clearly have some musculoskeletal cause, they can read this book, and it's different techniques on what to do. So they do trigger point release. They'll do that paradoxical relaxation I was talking about. And so what that is they like tighten all the muscles in the pelvis and then essentially like relax them after that. But it can be helpful for guys, especially that aren't interested in seeing a pelvic floor physical therapist for us. So with their protocols, they did a couple studies, and it does seem like there is some improvement. So they looked at 138 men treated for at least a month, and 72% moderately or markedly improved. And they had some workshop that was a 6-day protocol, about 3 to 5 hours a day. And then 60% of these men improved at least 25%. Overall, there's a 30% decrease in the score, and they improved in all domains as well. So I'd say for men with chronic prostatitis with the U-point system, I don't necessarily follow that specifically, like filling out the forms or anything like that, but I probably do use some of those kind of phenotypes as a guideline. So if they have, I'd say probably most guys get some, flow max in some ways, just because they usually do have some degree of urinary symptoms. And I use quercetin pretty commonly, just because the studies do show it seems to work okay. and there aren't really any side effects. That being said, a lot of guys just don't actually get the medication, so they never use it. And I don't know if my results are quite as good as theirs, you know, but it certainly doesn't hurt, and there's not a ton of treatment options for these guys. But kind of based on their other symptoms, I think offering some of those other therapies can be super helpful. But I'll take questions now. Does anyone have any questions?
Hello, we have a couple of questions already sent on your chat. We have a couple of questions already in your chat.
Yeah, I'm trying to see if I can get back to it. I think I have to stop sharing my screen. Hold on. Okay. Okay. So let's start at this first one. So when would I perform a orchiectomy for chronic orcalgia? So I would typically do a orchiectomy for chronic orcalgia, typically in the man who has failed a denervation, and a lot of times who's failed like an amniofix injection after that. That's usually probably who I would do it with. Try to avoid them in most guys. That being said, it's not a, you know, clear. Sometimes we do them earlier, sometimes we skip the denervation. It kind of depends on the patient preference in some ways. So performing a microsurgical denervation, you know, we do tend to do it with a microscope. That being said, could you do it with loupes, for example? Probably. The hard thing is identifying the artery. So we'll tend to use a small Doppler probe to help us identify the artery, which I suppose if you could do that with loupes, it's probably reasonable. We don't necessarily know yet, since most of these studies have been done specifically with a microscope, but it seems like it's probably possible. So can somebody have recurrent subclinical torsion for years? Definitely. So we see this in younger guys more frequently, and I've had guys come in who've had ultrasounds that show torsion that have since gone away. And it can, you know, happen on and off. So, and in those guys, we'll do an orchiopexy like you would for a torsion, and, you know, tack down both sides. It can be hard to, I wouldn't say there's too many people that meet that kind of symptomatology that come in. It's usually like a young guy who comes into the ER with severe pain, and you know, see evidence of it. But yeah, I would do an orchiopexy for those guys. So how do we explain testicular pain and chronic prostatitis? You know, I don't know exactly. I'd say it's a lot of the same pain, and you get a lot of referred pain going through the same nerve pathways. So like you very typically get pain at the tip of the penis as referred pain from bladder pain or prostatitis pain, I'd say it's probably just referred pain for the testicular pain, but we do see it very frequently. So non-pharmacologic therapies, does prostate massage have a role in chronic prostatitis? You know, it's kind of fallen out of favor here, maybe in part because it's hard to do, and there isn't necessarily great evidence in the studies that it's helpful for prostate massage, so I won't typically do prostate massage. I have heard anecdotal men that say they improve with prostate massage, and they'll, you know, like do it themselves. It's hard to say. I would say there's probably some guys that it does help in, but typically in most men with chronic prostatitis, there's not a huge role of it. And then our long-acting intralesional steroids, do they have a role in chronic or category 3 prostatitis? So, you know, I actually don't know. I don't know if there's any studies on steroids, intralesional steroids in prostatitis. I really haven't heard that done. I'd be interested if, you know, if you've heard anything, but I haven't read anything specific on that. And then traditional medicines, you know, we aren't typically using them that frequently, you know, just because they come to see us and we have our pathway and there's a lot there. But we have patients that come in who are using various traditional medicines, and they vary a lot based on the patient's culture. which for us, you know, we have people coming from everywhere, so it can vary quite a bit. And then, so Anne was once consulted on a 14-year-old with right testicular pain for 1 year that worsened over 2 weeks, clinically thickened cord with reduced flow. Yeah, that's kind of a tough one. So a lot of it's going to depend in part on exam. Sometimes I've seen a thickened cord quite a bit on these guys, especially at the time of surgery. And I guess there's some chronic inflammation maybe that's going on. It's not necessarily specific for one kind of pathology. Now, with the reduced flow, sometimes I'll do another ultrasound to see if that sticks around, or potentially this guy can have, like you were talking about before, some degree of a intermittent torsion, perhaps. Sometimes the flow will be reduced after they detorse, even though it's there. But it kind of depends in part on exam findings and what a follow-up scan shows. Allopurinol, we don't use all that much. It hasn't been shown to be superior for alpha blockers and 5-alpha reductase inhibitors. They have been used in the past, potentially. Fluoroquinolones for chronic prostatitis. So that is very frequently used as a first line, at least here in the US. We're kind of moving away from it just because it has not been shown to be incredibly common in guys to have a bacterial source of chronic prostatitis. So we're trying to move away from using fluoroquinolones as a first line for chronic prostatitis. I do say that men tend to improve with using fluoroquinolones, but they do have some anti-inflammatory properties. So it's probably pretty similar to them being on NSAIDs. So, you know, there are various risks of fluoroquinolones, resistances to those medications, as well as all the, you know, ligamentous and tendinous injuries that you can get. There's not like a particular time that you can use them for, as far as I know. I know with long-term use, there is some risk of having tendon ruptures and things. I'd say it's probably really based on it versus other sort of medications, not super effective for most men unless they have infectious signs when you're doing the testing. Experience with testicular pain after surgical treatment for BPH, and then urinary reflux into the ejaculatory ducts causing pain. I have seen a couple guys, it's not incredibly common considering how many men that we operate on for BPH. But I think theoretically there certainly is possible that they can have some urinary reflux that causes pain. Now, as far as response to tamsulosin, I would, you know, that's hit or miss. I think it's probably pretty similar to those men who respond to tamsulosin overall, in my experience. But we don't necessarily have data on if that helps or not. But men who have testicular pain after BPH treatment, I would probably put down this same pathway as treating other guys with chronic prostatitis. So we talked about prostate massage. And so post-varicocelectomy pain. So, you know, I do have some guys who have varicocelectomies whose pain is not typical for that of a varicocele. So men with varicoceles will have, you know, a dull, achy pain, worse at the end of the day, those kind of symptoms. So there are some guys with varicoceles, even large varicoceles, that don't have those symptoms, that I'll still steer more towards doing a denervation. So when you do a denervation, you're essentially doing a varicocelectomy. So kind of depending on what their pain is like, and some of those guys will just treat, you know, and do a denervation on. But that being said, there's a lower hydrocele risk with a varicocelectomy. So we'll try to do a varicocelectomy, but you can definitely do both at the same time. And yeah, so in cord denervation, I totally agree with you there on A number of cases recommend vasectomy because the vas has a lot of nerve tissue, but vasectomy reversal can improve pain in men with post-vasectomy pain syndrome. I don't think we know on what to do with the vasectomy or with the vas deferens. So what I'm guessing probably would potentially be maybe the right thing to do is like totally strip the vas deferens. So you can like really strip it down quite a bit and get most of the nerves off, I would think. Most of the nerves run along the vas deferens, not necessarily in the vas deferens. And you potentially don't get some of that obstructive pain that you would get from dividing the vas deferens. I don't think we know yet though. So, you know, studies aren't clear on what to do with the vas deferens, and it's just going to be kind of interesting to know in the long run when we have more studies to figure it out. Any other questions or anything? Well, thank you so much for having me. It was great. Hopefully it adds a little bit of a summary of what to do for some of these guys. It can be pretty tough for us. And I know a lot of it depends on your resources, but this is kind of how we handle it here.
Thank you very much. Thank you very much, Dr. Kelli.
Thank you. Have a great day.
Thank you so much, Kelli.
Thanks. Bye-bye.
Thank you very much, Dr. Kelli.
Thank you for attending, all of you. Thank you.
Thank you, Job.
Thank you, Job, for pulling us together.
Thank you, Job. Thank you, Job. It was nice.
Hey.
Please organize more, Job.
I agree.
And now, guys, the issue of putting an alarm helped.
Yeah.
Setting an alarm to remind you did help, and of course, Job's phone calls also helped. So that's a good strategy to keep it up.
Although you still came late, Chief.
We missed you.
I had trouble. I had two problems. One, my phone was being repaired when my alarm went off, and then I had trouble logging on until I figured it out eventually.
We also missed you in the odd round, Chief.
I missed you too. Why are you reporting me? Okay, bye. I'm starting my clinic.
All right. Good evening to everyone.
Yeah, thank you, thank you.